Welcome to this month's ITA webinar on medical professionals' role in clean sports. My name is Mary Irvin and I am a member of the education team at the ITA. And a big thank you again to everyone joining us. I could see as the intro music was playing, we're getting people joining us from all over the world. I only had the opportunity to look at the first few, but hi to you from Mexico, Panama, Malaysia, the Philippines, Uruguay, Finland, Zimbabwe. You guys were the first to say hi in the chat. So a big thanks to all of you. Now, joining me today, I'm delighted to welcome three expert guests on today's topics. They are going to switch their cameras on now so that you can see them as well. So first up, we have Dr. Lucienne Attard. Now, Dr. Lucienne is a member of the ITA's International Therapeutic Use Exemptions Committee. Welcome to the webinar.
Hello, everybody. Thank you, Mary.
Next up, we have Dr. Carole Okoth. Now, Dr. Carole is a member of the ITA's Health and Clinical Expert Advisory Group. Welcome to the webinar, Carole.
Thank you, Mary, and welcome everyone. Welcome to our webinar. Thank you.
Thank you. And then we have Dr. Mark Stuart. Now, Dr. Mark is the ITA's Drugs, Health and Development Senior Manager. Welcome again, Mark.
Great to be here, Mary. Thank you.
Fabulous. Now, I'm going to be talking to you all individually and then bringing you all together at the end for a live Q&A. So for now, you can sit back and relax. And Mark, I'll come to you first in just a few moments. Now, to get the most out of today's webinar, we are offering translation in Arabic, French, Russian, and Spanish. As I mentioned, we'll also address some questions live at the end of the session, but you can write them in the Q&A box at any time. And a final housekeeping point from me, we are recording this session. Now, before we jump in, I want to say thanks to our official presenting partner, Informed Sport. Now, their support of these webinars allows us to deliver them free of charge to the clean sport community across 5 languages. Informed Sport is a global certification program for supplements that batch test products for substances prohibited in sport. A supplement contamination continues to be one of the leading causes of inadvertent doping. We encourage athletes and athlete support personnel to check all products before use at sport.wetestYouTrust.com. Now, today's session is an introductory one for those medical professionals new to anti-doping. Medical professionals play a key part in supporting athletes and must understand the anti-doping landscape and their associated responsibilities. Today, we're going to look at your role in protecting clean sports, supporting athletes, and operating in line with anti-doping rules by covering 3 main areas of medical practice: the prohibited list, therapeutic use exemptions, and looking at the role of team physicians at events. Now, these are just some examples of roles and responsibilities. We can't cover them all in one session. But importantly, what everybody does need to know is that anti-doping is based on the principle of strict liability. This means that an athlete is solely responsible for everything they use and that is found in their body. And an anti-doping rule violation will occur whether or not an athlete intentionally or unintentionally used a prohibited substance. It is never an excuse for an athlete to say, "I didn't know," or "my doctor gave it to me." The athlete will face the consequences. So here we see that athletes are bound by the principle of strict liability, but clearly they also rely on medical expertise. And this is where medical professionals have a duty to ensure that any treatment or advice does not put athletes at risk of anti-doping rule violations. Equally, there is also a duty to identify athletes who may be at risk of doping and have the confidence to intervene to protect their health and their sporting future. And we plan to have a follow-up webinar to explore these areas. For now, I'm going to leave you with an outline of your roles and responsibilities on your screen. Now, the last thing I want to mention before speaking with our panelists is that doping is defined in the World Anti-Doping Code as the occurrence of one or more anti-doping rule violations. As you can see on screen, there are 11 of them, and 7 of them are applicable to you as medical professionals, and you can see them pointed out to you now. So with that as our introduction, let's dive right in and take a look at the prohibited list. And over the next few minutes, we're going to cover all key aspects of it. Welcome back, Mark.
Thank you very much, Mary. And thank you. Brilliant. And thank you for those introductory words as well. Some really important topics to cover today. As you said, I'm going to cover the prohibited list to start with. Now, this is it's the international standard published by the World Anti-Doping Agency, and this defines which substances and methods are banned in sport. This includes a number of common medications that healthcare professionals should be aware of if they're working with or treating athletes. As a healthcare professional supporting athletes, it's very important that you know where to find it and are familiar with what's on it, so that you know how to check whether the medications you plan to prescribe or administer to your athletes are prohibited or permitted in the sports that your athlete patients compete in. The list is a constantly evolving document, and it's updated at least annually, so it's really important that you always check for any updates. WIDA publishes the version for the upcoming year in October, which comes into effect on the 1st of January. So there's a short window really to review all of the medications of your athlete patients, and to also consider whether these changes may impact your prescribing choices going forward into the year. Now, occasionally changes are made mid-year, so if you take a new decision about whether to prescribe, administer, or recommend a medication to an athlete, always refer to the WIDA website for the current list, so that you're basing that decision on the current rules. Now, I would recommend that you always keep a copy of this close to hand in your practice, your clinic, or your pharmacy for quick reference.
Thanks, Mark. So now we know where the substances can be found on this prohibited list, but how does a substance make it onto the list in the first place?
So a new substance or method can be added to the prohibited list if it's deemed to meet any 2 of the following 3 criteria. Now, firstly, it has the potential to enhance sport performance. For example, that they can make the athlete run, swim, or compete faster or for longer, or lift heavier weights, or feel less pain, so they can push themselves a little harder. Secondly, that the substance or method represents a health risk to the athlete. Now, many of the drugs on the list fall into this category based on some of the serious side effects that they can have or their negative impact on health. For example, and as healthcare professionals will know, anabolic steroids, for instance, can have serious cardiac side effects, which can result in increased risk of heart attack. Some of the narcotic drugs, such as Tramadol, morphine, or fentanyl, can also have serious risks of addiction. And of course, cannabis use has also got widely documented health risks for users. Now, the third criteria is that the substance or the method violates the spirit of sport. Now, the spirit of sport really covers many aspects, but many concepts really, but in essence, it's the values relating to ethics and fair play. And I always say if something is being used with the intention to cheat, then it is probably going to be against the spirit of sport.
Thanks, Mark. So for all the medical professionals listening and who are maybe new to this, obviously the list outlines in detail the substances that are prohibited, but can you give us a bit of an overview of what these might look like?
Sure, this is a really important question, Mary. Firstly, let me give you an overview of the sections of the prohibited list. You can see a summary of these on the screen. You can see that it consists of substances and methods prohibited at all times. Now, that is every day of an athlete's life, including when they're not competing. It also has a section of substances including medications, prohibited only during the in-competition time, which is from 11:59, close to midnight the night before the event, until the end of the doping control process. And it also has a section that describes substances that are only prohibited in certain sports. Now, beta blockers, which are a medication commonly prescribed for cardiovascular conditions, are one of the is the particular category of drugs where sport-specific rules apply. Now, if the athletes you are treating compete in any of the following sports you can see on the screen, this class of medications will be prohibited for them during the in-competition period. And a few examples there: archery, billiards, darts, golf, skiing, snowboarding, underwater sports, and automobile driving. Now, it's very important to know that there are other common medications that are on the list, which are also prohibited in sport. And some of the examples include this list on the screen. Diuretics like furosemide or spironolactone, insulin for treatment of diabetes, including both of the fast and the long-acting types of insulin, glucocorticoids, which are used for inflammation, including injections of triamcinolone, betamethasone, things like oral prednisolone and prednisone, to name a few. And the ADHD medications include many of the stimulants, things like dextroamphetamine, methylphenidate, and lisdexamphetamine are commonly used for ADHD treatment. Now, as the medical experts will know, many of these medications may be an essential part of the patient's treatment plan. And so if they are needed for legitimate medical treatment, there is a mechanism to apply for a therapeutic use exemption for these or any other essential medications. Now, Lucienne will cover this in depth shortly. At the end of the day, as you said before, Mary, the athlete really is responsible for any prohibited substance that is found in their system. But healthcare professionals also have a very important professional role in terms of providing accurate information and supporting the athletes so that they can avoid testing positive. Now, the rules are clear, the consequences are very tough and potentially career-changing for athletes. So both healthcare professionals and athletes need to take this really seriously and be very vigilant about the medications that are prescribed, administered, or taken by athletes.
Thanks, Mark. Now, on the last slide that you just talked about, asthma was the first bullet point on there, and that's a pretty common medication amongst athletes. So it's maybe worthwhile taking a bit of a deeper dive into this one. What else would you like to tell us?
Sure, Mary. Just briefly, I guess, so the beta-2 agonist category on the prohibited list contains many common asthma medications. Now, all the selective and non-selective beta-2 agonists, including all of their optical isomers, are prohibited. And there's some examples there on the screen. We have the short-acting beta-2 agonists like salbutamol and terbutaline, and the long-acting beta-2 agonists like formoterol and salmeterol. Also, the ultra-long-acting types, these have once daily dosing, and some of the newer types of beta-2 agonists like vilanterol is a common example. Now, there are some exceptions to beta-2 agonist dosing for some medications. Now, this allows for the normal use within the manufacturer's recommended dosing. Now, this applies only to the 4 medications shown on the screen. Now, from this table, you can see that the permitted maximum dose over 24 hours for vilanterol, salmeterol, formoterol, and salbutamol in column 2 falls within the most common maximum daily doses as recommended by the manufacturers. For example, you can see the maximum recommended daily dose of salmeterol is 100 micrograms twice a day, which adds up to 200 micrograms over 24 hours. And up to 200 micrograms per day over 24 hours is permitted in sport without a TUE. But as healthcare professionals will know, occasionally higher doses than the recommended manufacturer doses may be deemed necessary for some patients. And so anything over these doses will require a TUE. Now, all of this is outlined on the current prohibited list, so please check these carefully, particularly if you treat athlete patients with asthma.
Thanks, Mark. Now, when we were preparing for this session, we were really trying to focus on, some of the key things that we could get through in a limited amount of time. I know you were very keen on explaining in more detail the concept of a washout period and what that means in the context of doctors prescribing medications to athletes.
Absolutely, Mary. So one of the most significant changes for the list back in 2022 was the prohibition of local injections of glucocorticoids during the in-competition period. And as such, now all injections of glucocorticoids are prohibited in competition. Now, their use really does require special attention by sports physicians, as local injections are widely used in sports medicine, mainly to treat common inflammatory musculoskeletal conditions such as capsulitis or bursitis. Now, local injections of glucocorticoids can provide fast reduction in inflammation, leading to pain relief and improvement of joint function and motion. So they do have a role in sports medicine in some cases. And we also know that after glucocorticoids are administered, they can still be detected in the urine at the time of a doping control test for some time afterwards. Now, this really can be a challenge for physicians to accurately determine how long these drugs stay in the body. And so recently, WIDA published some very, very helpful guidance on the washout periods of glucocorticoids to help physicians consider when they can administer them in relation to the athlete being tested so they don't test positive. If I may go on there, Mary. So firstly, just a very quick definition of what a washout period is. Now, this refers to the time from the last administered dose to the time of the start of the in-competition period, which, as I said before, was 11:59 p.m. on the day before competition. Now, this table shows the washout periods for various glucocorticoids. Now, you can see that the washout varies from somewhere between 3 days up to 60 days, depending on the drug and the route of administration. For example, local injections of triamcinolone have a washout period of 10 days. Now, local injections of other glucocorticoids, such as betamethasone, have a washout period of 3 days. So it really does vary. Now, with such washout periods now being better defined, clinicians have much more information to base their decisions on regarding the selection of different types of glucocorticoids for the treatment of their athletes. On this table as well, there's helpful guidance for oral and intramuscular routes of administration too. Now, I should note that these washout periods are based on the use of these medications according to the manufacturer's licensed doses. So in principle, if the glucocorticoid needs to be administered via prohibited route within these washout time periods, a TUE may be required. And again, Lucienne will cover this shortly. The most up-to-date washout period guidance is on the WIDA website, so I encourage you to take a look at that.
Thanks,
That's
Mark.
Yes.
Let's cover another key change that was made earlier this year. On the 1st of January, Tramadol was made prohibited. Tell us a bit more about that, please.
Yeah, this has had major implications for healthcare professionals working in sport. So Tramadol has been added to the narcotics section of the prohibited list this year from January, and it's now prohibited in competition. Now, many of you know Tramadol can mask pain, and it has been known to be misused, particularly in sports such as cycling. And a recent study demonstrated the potential performance-enhancing effects of this drug, specifically in cyclists. Now, this has implication for prescribing physicians. Now, firstly, this is a common medication used for severe, painful sports injuries. And secondly, it's carried by a lot of medical team doctors for the administration of pain in an emergency setting, often on the field of play. Now, this new prohibition doesn't mean that this cannot be used medically for pain relief, but it does mean that if you need to prescribe this, you have to apply for a TUE or a retroactive TUE if it's needed in an emergency. So I guess physicians now have two choices with regard to Tramadol. Either find a permitted alternative, and one example might be an injectable non-steroidal anti-inflammatory drug, or indeed apply for a TUE.
Thank you. And last point on the prohibited list here is how else can people check if something is prohibited, particularly thinking about athletes here as well?
Yes, yeah. So you'll be pleased to hear there are a lot of resources out there to help both healthcare professionals and also the athletes that you treat. A very good resource that I want to mention is globaldro.com. Now, if you live in Canada, the UK, USA, Switzerland, Japan, Australia, or New Zealand, you can search for the brand names of the medications in your countries to find out what the status is. But an athlete or healthcare provider in any country can look at the status of an ingredient, a generic ingredient, or find links to other international websites with information specific to medicines in your country on this site as well. I'd really encourage all medical professionals to check this out if you haven't already. And I should note, the ITA, we advise athletes to always ask their doctor or pharmacist if they've got a query about drugs in sport, if they want to know the status of a particular drug. So you really are the experts in medicines and can really help athletes interpret this prohibited list. It's a very complex document, but you will have the knowledge to be able to decipher it and present it in terms that athletes can understand. So it is really important for you as healthcare professionals to really understand this so that you can best support your athletes. Just quickly to note, many national anti-doping agencies have advice lines or websites, and they have experts also to hand to potentially help with your questions or the athletes that you treat, particularly in your country. So have a look at some of the local resources that might be available to you in your country. That's
Thanks,
all on that one.
Mark. And my
Yes.
final question to you, and a brief answer, please, is we may have some physicians online who are preparing for Paris 2024 Olympic Games. Can you briefly explain the IOC Needle Policy, please?
Sure. Well, this is very important for physicians who will be working in Paris 2024 at the Olympic Games. So the IOC Needle Policy applies to all injections given during the Olympic Games. And the policy states that needles can only be used by qualified medical practitioners for the clinically justified treatment of injury, illness, or other medical conditions. And now, if you are working as a team physician there, you must declare all of the injections that you make outside of the polyclinic to the IOC. Please check the IOC website, the ITA website, or the Paris 2024 Medical Guide, which has all the details about this and the link to the online needle declaration platform. Mary, I know we're pushed for time. I'm going to hand back to you. I'm happy to take any questions later on in this webinar too. Thank you.
Fabulous, thanks. See you in a little while. And that just leaves me to say welcome back to Lucienne, who's going to talk us through therapeutic use exemptions. Nice little segue there from Mark, who mentioned the word TUE several times during his segment, Lucienne. This TUEs, really, we spent time talking about substances and methods that are prohibited in sport, but clearly there will be times when an athlete does need to be treated with a prohibited substance, as Mark mentioned throughout his presentation. Can you provide a bit more context on what is a TUE?
Hello again, Mary. Okay, so sometimes athletes can have legitimate conditions, chronic or acute, that require drugs that are prohibited. As Mark said, they would be on the prohibited list. Now, there is a way that they can be granted, let's call it permission to use them without consequences of anti-doping rule violation through therapeutic use exemptions. So, but however, there are some strict conditions that have to be met before this permission or TUE is granted. So an athlete who would have a TUE in hand would not risk having an ADRV or getting sanctioned. So the conditions that need to be fulfilled to get a TUE granted, we're seeing them on the screen and we'll go through them. So the first one would be that the athlete health will be significantly impaired if they do not take the substance. So for example, let's take insulin-dependent diabetic. If we cannot prescribe insulin to this athlete, his health condition will deteriorate very badly over time, or they can be acute medical complications. Number two, the substance does not enhance performance beyond what brings an athlete back to normal health. So what we're saying here is that the drug should bring the athlete back to what other athletes who do not have the same, who are not sick, are able to perform. Number three, and this is very important, there are no alternative treatments available that are not prohibited. Let's take diabetes again. There is no alternative to prescribing insulin at the moment. So therefore, there are no alternatives. However, let's contrast that with hypertension. We have a whole load of drugs which are treating hypertension. So I think physicians' first choice would be drugs that are not prohibited for this condition. So you see there are alternatives there. Point number 4 is the need for the use of the prohibited substance is not resulting from prior use of a prohibited substance. So we are trying to treat a condition which came about as a result of using a prohibited substance. And as we're seeing in red over there, all the 4 criteria need to be met.
Thank you. And if you believe that all 4 criteria are met, what would the next steps be for a physician and athlete?
Right. So an application needs to be made to the anti-doping organization of the athlete. So here we have to decide, or at least the athlete has to decide which anti-doping organization they belong to. If they are international level athletes, they need to apply to their international federation. If they are national level athletes, then they should apply to the National Anti-Doping Organization. So that is the first step. Then there is the specific TUE form that needs to be filled in by both the athlete and the doctor. So the athlete has his part, the doctor has his part to fill in with the condition, the medication, the doses, etc., etc. And then this needs to be submitted to the anti-doping organization. The ADO then will pass it on to its TUE panel, who will consider this application and make a decision, which is then communicated to the athlete.
Thank you, Lucienne. And I'm sure you must have some top tips as to how best fill in these applications as well. I'm sure in your experience also sitting on a panel and seeing applications come through, you must have seen maybe omissions that may have delayed the process. So what advice would you give our listeners?
Okay, so first of all, it's very important to make a readable application. Best way is to have it computer written. If the form is filled in by hand, the handwriting needs to be legible. You need to understand that we don't always read everybody's handwriting. If that is not possible, then writing in block letters would be best. So that's one thing. The exact diagnosis needs to be listed, preferably with the code, with the IDC code with it, and the exact name, chemical name of the drug with the dose, route of administration, and for how long it's going to be administered needs to be clearly set out. Very important, we're looking at the slide here, is that to include accompanying medical documentation. So just filling in the form is not enough. The TUE panel needs to be satisfied that the condition that the athlete is suffering from is legitimate and therefore needs to see how the diagnosis was made. So things like laboratory reports, imaging reports, clinical reports from the treating physician, the history of the patient, how the condition started, how long it's been there, how it's been treated in the past years or whatever the condition is, how it's being managed. All these are important. So it's just handing in a form by itself is not enough. That will delay the process. And as you rightly point out in this slide, WADA on its website have got a lot of documents that physicians can consult. So we have the guidelines and we have the checklists. So there are guidelines for specific medical conditions that specify exactly what the condition is, how it's investigated, how it's treated. And there are also the checklists which indicate which documents are required for therapeutic use exemptions that need to be accompanying the application. Can go one slide back, please. Another point is, please do not include drugs that are not prohibited in the application. So sometimes we receive applications with like 4 or 5 drugs and only one of them is actually prohibited. So whatever is not needed doesn't need to go in the application. Chemical names rather than trade names would help. Even doubt list both of them, please, because not all countries have the same trade names as other countries. And then make sure that it is submitted correctly into the right portal, either ADAMS or to the anti-doping organization.
Thank you. Now, we saw the resources slide pop briefly up there as well, and you mentioned the WADA guidelines and checklists. Maybe we can take a few seconds just to point out what those are and why they could be useful.
All right, so on the top part, we're seeing examples of guidelines. So we're seeing here inflammatory bowel disease, intrinsic sleep disorders that are for ADHD, diabetes. There are a whole list of conditions that WADA have provided physician guidelines. And these are very detailed, targeted to the physician. So maybe non-healthcare persons might find it a bit difficult to follow, but it's still doable. On the bottom, we're seeing the checklists. So again, there are checklists for TUE application for different kinds of conditions. So here we're seeing ADHD, pain management, adrenal insufficiency, and anaphylaxis. Those are just a small sample of what is available. Also on the left, we are seeing the international standard for therapeutic use exemptions. So that is what ADOs follow and TUE panels follow for granting or judging therapeutic use exemptions. That is another resource that is available by WADA.
Thank you. Before we go on to look at retroactive TUEs, would you like to summarize in any more detail the sort of most common conditions that you are seeing TUE applications for, or do you think you've covered that already?
Oh, we can talk about that, yes. So I think the commonest one, the number one spot is ADHD. We get a lot of applications for the treatment. Mark mentioned them before. They are the methylphenidate and the amphetamine group of drugs. And these, of course, are stimulants and need to be covered by therapeutic use exemptions. Now, one comment about ADHD applications is that this is one situation where we really require a physician's report to accompany the therapeutic use exemptions besides other documentation. So there would be the psychologist's report, the scores, but definitely the treating physician needs to give us a nice history of how this athlete was diagnosed and how he or she was treated during the past times. Did I mention that we need a medical report sometimes before for other conditions? Yeah, I think I did.
Okay, thank you for that. Now it's time to get the audience involved a little bit as well. So I'd like everyone to make sure they know where the chat is, because we mentioned earlier that TUE applications must be in place as soon as possible, and also that a TUE must be in place before starting treatment unless it's an emergency. So let's take a look at that situation now. I'd like our participants to write in the chat any ideas of what they believe could be examples of emergency drugs or situations where a substance may be given without having the TUE in place. And then I'm going to ask Lucienne to do a brief summary of what we're seeing in the chat. So if anyone would like to pop anything there in the chat. And while we're waiting, Lucienne, maybe you might also want to proactively give some ideas. I can see one come through already, adrenaline.
Yeah. May I make a comment, Myri? Maybe I forgot to mention it, that yes, athletes should not start medication before they have a TUE in hand. The only exception is if it's an emergency situation and the athlete's health would suffer terribly if he's not given the drug, then that is acceptable. And we saw already one for adrenaline here. So adrenaline is used in severe anaphylaxis. Yes, that is acceptable. When an athlete has a severe anaphylactic reaction, they obviously need adrenaline or an EpiPen to be used there and then. I'm seeing also morphine for injuries, narcotic analgesia, if there is a documented injury. Yes, it is an emergency and it would be justified if it's accompanied with the right reports, of course. Asthmatic crisis. Yes, I'd like to elaborate more on asthma. So Mark mentioned that there are limits to the dosing that athletes can use without needing to apply for a TUE for the beta agonists. When an athlete is having a bad asthma attack and taking the inhaler, but it's not working, they need to be given a high dose salbutamol, for example, by nebulizer. And that falls into requiring a TUE because it would be a higher dose than is actually allowed. So yes, if there's an acute asthma attack, that is acceptable as an emergency treatment, and it would require a retroactive therapeutic use exemption application.
Thank you. Lots of comments coming through in the chat now. We don't have time to go through each one in detail, but Lucienne, before we conclude, just looking at the outcome of a TUE application, any other situations you'd like to touch upon in terms of retroactive TUEs?
I think we had a slide on this, Myri. Yeah?
Yep, we'll move to that one now.
Okay, so as we said, there is a possibility to get a retroactive TUE under certain circumstances. So that means applying for it after the episode has happened. And the first one that we have talked about is an emergency or urgent treatment was required. So I think we made examples of that. There are several in the chat. And of course, when that happens, then a TUE should be applied for as soon as possible after the event with all the required medical documentation to justify the use of that drug in that situation. Second point is that there was insufficient time, opportunity, or other exceptional circumstances that prevented the athlete from submitting a TUE application or having it evaluated. Sometimes athletes may find themselves with their medical team, of course, in a situation where they absolutely could not ask for a therapeutic use exemption. These are really rare, these situations, and honestly, I haven't seen much of these applications. However, it may happen, and it needs to be justified, of course. If there is good justification, then it may be granted. Point 3 is that sometimes athletes who are not at international and national level are not required to actually ask for a therapeutic use exemption before participating in sport. But when they do then participate and they get tested, then they are allowed to apply for a retroactive therapeutic use exemption. However, please note that still there has to be all the documentation provided as for other athletes to justify using a prohibited substance, even in low-level athletes. Last point, and this one is goes on with what Mark was saying. The athlete tested positive after using for therapeutic use reasons a substance out of competition that was only prohibited in competition. For example, glucocorticoids given, let's say, 3 days or 4 days, depending what it is, before competition might actually result in a positive test during competition because of the washout period of that drug. So in this situation, if a doctor is in doubt how long the washout period is, it's best to apply for a therapeutic use exemption when the injection is being done or the treatment is being done rather than after. However, it might be possible also to apply after, making sure, of course, that all the important documentation is accompanying the application.
Thank you, Lucienne. And briefly, just in summary, we want to finish off looking at the life cycle of the TUE. How do people know if and when it is granted? Could you help us conclude this section?
Right. So once the athlete submits his application, the ADO passes it on to the Therapeutic Use Exemption Committee. And may I add that all ITA applications are received by the panel in a redacted form. We have no idea who the athlete is. They are anonymized. So there is a level of data protection also surrounding these applications. The panel, who are made up of medical physicians, specialists in their own right, will consider the evidence that is made available. If we need more evidence, we're going to ask the ADO to ask the athlete for more evidence. If, however, we have all the documents in place, then we can make a decision. And the decision would be either to grant it with a time limit, there is always a time limit attached to it, not granted, or ask for more evidence. Maybe that might have been lacking, so we can decide better what will happen. And then the anti-doping organization will communicate this with the athlete and issue the certificate if it has been granted.
Thank you so much, and we look forward to having you back for a couple of minutes at the end when we look at the Q&A. I can already see that we have quite a lot of questions. Thank you again, and I'm going to transition now to welcome Carole back. Hi, Carole. Hi, let me just check that I can hear you.
Okay, sorry, I was just muted briefly. Can you hear me now?
Fantastic. Yes, yeah,
Okay.
that's great. So we've heard a lot about the prohibited list and then TUEs. Let's now put you in situ at an event, and we're going to get straight in because, again, as we were preparing for this session, I love 2 images that you showed me to get our audience thinking about your role as a physician looking after athletes at an event.
Okay, thank you for the welcome, and thank you once again to the participants. So these slides, actually, I'm a very visual person, and I hope to my colleagues and those who are attending, we're able to see the role that team physicians play. So on the left, we have a figure from the Hong Kong Sports Institute. It just shows the central role, or one of the, not the central, but the key role that the team physicians play in the athlete development. So I know sometimes for the physicians who are on their fast assignments or those who are coming into a setting where a physician hasn't been before, sometimes you question, your role and what you're doing there. But just take confidence that you belong. You're part of the team that contributes to the athlete's success. On the right, we have a mind that's really filled with a lot of thoughts. And again, to those who are starting or having their first assignment, or those who are given a really large assignment like the upcoming Olympics or the Paralympic Games, there's so many thoughts running through your head. And as we've had from my colleagues, Mark and Lucienne, there's quite a bit to do. Anti-doping is just one of those rules. So hopefully at the end of this, we'll be able to help you just put everything into context so that you deliver your role successfully. Thanks, Mary.
Thank you then. Now that we've set the scene, maybe we can go straight into the global planning then. How do you process all of those thoughts, and what advice would you give to physicians maybe doing this for the first time?
Okay. Sorry, maybe just go back one slide.
You want to go
Sorry,
back
I
one?
think,
Sure.
yeah, just back one slide. And I know a lot that has been said will make you feel as a physician that you're back in the hospital or a clinic. And just as we try to sort of understand what the sports environment is like, it's not the nurse or the ward in charge, but we have quite a number of stakeholders that we work with in that environment. As you can see, we have government officials, sports federations. There's you as a physician, the colleagues you're called to work with. You have the athlete. You have to think about, the season, the pre-season, in-season, post-season, the competition, whatever legislation there is around managing athlete health, and even looking at how to work with the coaching staff and the administrative staff so that you're able to now deliver this role, not in a hospital, but in a sports environment, which is sometimes out of that traditional setting. As we look at then, so how do we interact? Like as we are planning, how do we interact now with the next slide, how we are interacting with that environment to ensure that whatever it is that we need to do is done. So a lot has been said by my colleagues, needing to have, the right health evaluations. For example, if you were to prescribe a drug, you really have to, evaluate the client appropriately. So in this case, we have our periodic health evaluations, our pre-participation screening that we usually do. And by ensuring that those are part of your plan, as a physician, you're able to pick out athletes with health conditions that will require, medication, whether these are on the prohibited list or not. So with that approach, you're able to now justify why you're putting people on treatment, and if it is a prohibited drug, the reason why you pick that drug. So in addition, it's also important to have your evaluation of the athletes through the season. We know sometimes you may not pick an issue at the beginning of the season, but you pick it as the season continues. So it's important to have those processes in place throughout the season, whether it's you who's doing it or you're working in a team with many more physicians or many more health professionals. And this would even involve issues such as performance or fitness evaluation. We see that a lot of times, as has been mentioned, in the nutrition space, people want to use substances, whether pharmaceutical or non-pharmaceutical, to improve on their recovery, to improve on their strength. So being aware of what is involved in the fitness parameters and working with, for example, the strength and conditioning coaches, the nutritionists, so that you're on top of it as well as a physician, and you're able to also, contribute to that discussion. One of the areas I look at, and I think I had some issues with, and sometimes we have this when we are working as new physicians, is how to work with the administrators and the coaching staff. So as I mentioned, you really have to be clear about the season, for example, the season plans. The administrator, for example, will help you schedule your periodic health evaluations on time. For example, bringing on board an anti-doping liaison officer who will now help you as the physician, for example, to ensure that if there's a TUE, it's filed in time. The athletes are actually given a conducive environment where they can discuss their health problems. They ensure that they come on time for the anti-doping education, for example, because without this education, just as we're seeing as physicians, sometimes it becomes very difficult to be compliant and to understand what's happening. The coaches will give the plans in terms of performance targets for the athletes. So once the coaches understand where you're coming from, where the nutritionists are coming from, you're able to come together and create plans that are likely to be doping-free without your input, and the nutritionists and, for example, the S&C coaches, you find sometimes the coaches will take over that role and sometimes even deliver medication when they're not supposed to. The other thing I would look at is just even preparing the athlete, in addition to educating an athlete in terms of what what to expect, or rather what is prohibited, how to conduct themselves when they're interacting with physicians. Another area we should actually teach or educate our athletes is on preparation for sample collection. We find that sometimes the athletes become very apprehensive when that is coming through. They don't want to give samples. They're afraid of being pricked. But then through this education, we hopefully are able to get our athletes to collaborate or rather to cooperate with the anti-doping officials better. We've already mentioned the TUEs, the retroactive TUEs. These are the documents that as physicians we need to fill. And clearly those have to follow logical sequences and processes, just as we do in our other traditional settings. And being clear on what is being given, the alternatives that are available, the dosing, the sport events, for example, as Mark mentioned, so that you're very clear on who needs a TUE and how to actually fill it. And one other thing I keep forgetting is to ensure that as a physician, you have your documentation in place, your licenses, for example, because sometimes we forget because it's so busy when you're on assignment to even check what is necessary for your country where you're practicing, or when you're traveling abroad to ensure that you're within the legislation on that side. So remember that you'll be signing a lot of documents that may be used in court or may be used in court-like processes. So you have to be on top of your license and all the legislative requirements that are there. And also understanding scope of practice, knowing who you are. For example, if it's a cardiologist, it's a general physician. And as I just even mentioned with the coaching staff, sometimes just having that clear discussion with the team about who does what at what time, so that people are not breaching any of the laws of the country. I think generally in terms of the global planning, that is how I would approach it and sort of give it a more on-field feel, so that hopefully the physicians and those who they're interacting with in the sports field understand what needs to be done.
Thank you, Carole. And again, when we were planning for this session, I loved some of the checklists that you told me about, and you asked different questions: the what, the where, the when, the who, and the how. And thank you so much for agreeing to share all these with this audience, and we will send the slides to everyone at the end too. But maybe we can look at those next 3 slides. So the first questions that you were asking yourself were the what, the where, and the when. So maybe you can take us through your thoughts on this one.
Okay, so hopefully if you could have this checklist, I think if, for example, you're working with very big teams, you need to be very clear on what needs to be done, when, by who. So if this, as I share with you, would be something useful, I would advise to have it probably in a format similar to this. So as we're looking at the what's, we've mentioned that you have assignment specifics, duration. Sometimes you're called on board for very short tournaments or short events, but sometimes you're called to work with the team, for example, on a longer term contract. We've mentioned whatever documents you need as a physician. And also in this case, you also have to remember when you have other medical professionals in your team to ensure that they are also on top of their medical licenses and those other requirements. Scope of practice I already mentioned in passing, but I could mention it again so that people are very clear. Mark mentioned, for example, who is to deliver injections where they're needed, who is to treat athletes when they're needed within the team setting or the delegation. As we look at where we mentioned in terms of regulations within your own country of practice, and even as you travel abroad, what is needed, and ensure that whatever documentation you need to send forward is sent on time. I know sometimes it's difficult. It's not this information or your appointment comes in a bit late, but it's important to ensure that you file that as soon as possible so that you're not breaching any of the regulations on the other side. And as we look at in competition, we've seen the doping regulations cover in competition, out of competition drugs. So you need to be very clear what covers the in competition period, what covers the out of competition period, so that as you're planning for medication, especially where it is needed, you're able to clearly define and know what to do.
Thank you. Let's move straight on to the who questions, shall we?
Okay, so the who. So who is in your delegation? So I'll just look at this overall in terms of the whole team with some emphasis on the athletes. So as you look at your delegation, this looks at your athletes, the coaching staff. So I think one of the things we have as an anti-doping regulation violation is trafficking. So you should be careful that should there be anyone in your delegation so who is not an athlete and you're carrying medication, for example, for a staff member, for example, ensure that the necessary documentation for that individual is with you or is with that individual, so that should they be found with it, it's not said that the medication is being carried for doping purposes. As we look at the athletes support personnel, who are the medics and non-medics. So for example, you have physios, you have doctors, you have nutritionists, psychologists. So just understanding who is who will also help you to sort of put the roles together. You know who to consult when you have a nutrition question. You know who to consult when you have an issue on performance. When we look at the support for the anti-doping processes and the anti-doping training, we've mentioned the administrators. So work on having a very good rapport with them, because they will align the team for you. You don't have to, as a physician, for example, go calling people or rallying them to come for the sessions or for their evaluations. You'll have your administrators doing that for you. And the coaching staff also just understanding clearly who they are, what their understanding is, and how to engage with them.
Thank you. And then finally, the how. How do you bring all of this together?
Oh, that's a very good one, a bit tough, but then we can handle this so that we're in the right place. So just looking at all these things, and so in your list, as I've mentioned, if you've already carried out your periodic health evaluations, you'll have a very clear list of who needs what and at what time. Try and work on, creating a rapport with these stakeholders, your coaches, your athletes, the administrators, so that whatever needs to be done is done on time. As you put into context, for example, when the games or the competition is starting, for those who are, for example, on the registered testing pool, you understand then how to deal with them. So just make sure you understand clearly who needs what and at what time. When you need to put in your TUEs, ensure that the TUEs are written on time. We have, I think, a month before the competition date for majority of them. For those on the registered testing pool, you need to understand that that is probably throughout the season. The needle policy, so for those who are requiring insulin and anything else that is delivered as an injection, ensure that you yourself are well educated on what that needle policy is, and where there's an athlete who is using that, their appropriate documentation is there. The sport-specific regulations, we've seen some of the medication is banned in some sports, so be aware of that with the athletes you're dealing with. The athlete health and performance needs, as I mentioned, there's a point where your athletes will need to recover, so you understand what that period is and how to work with the coaching staff so that the athletes are not using performance-enhancing drugs or substances, for example, to meet their needs. As I mentioned, creating a conducive environment where athletes are comfortable to speak. I know a lot of times they will hide their injuries and they'll hide their health status, but when you create this conducive environment, they'll comfortably speak to you or another staff member, and you're able to take care of them. With anti-doping education, I mentioned it's critical, because people tend to not follow when regulations when they don't know. So you train your athletes, the coaching staff, and the other athlete support personnel so that they're very clear on what needs to be done. I personally like setting up a multidisciplinary team, especially when we have multi-sport events or large events. It's not always the case, but should you have a larger team, I find it very useful if you have the different categories, as I've mentioned, your PTs, your nutritionists, psychologists, so that you're able to have these roles with the people who are actually best trained to manage them. And you're more like having consultative sessions rather than having to be an expert who knows everything. In terms of medication, once you know whatever is needed, you have your lists. And remember that some of this medication may be banned, especially as you're looking at travel across borders, or some things that need to be declared. So you have to be very clear on what you're carrying or what you're handling in the camp. Remember the issues of also trafficking. carrying needles as well, for example, where they're not needed. Then we mentioned role-specific checklists, especially where you have a larger team that's working under you or working with you. The management of health, we've mentioned just having processes where athletes can be reviewed through the season, not just at the beginning of the season. Having these medical records filled in appropriately, logically, at the right time. They will be used, for example, for TUEs. If someone is presented to court for a doping violation, your documents may be used. And then having a work plan that's actually documented with all this, the who, the what's, and the when, so that you can always refer to this work plan and also use it for monitoring and evaluation processes to see if you're delivering quality services. And then also where you perform procedures or you're referring your athletes to other healthcare professionals to also be very clear on that. Yeah.
Thank you so much. And I think we're going to leave the audience with a sort of takeaway messages slide. I'm very conscious of time. Is there anything that you'd like to sort of verbally say to this one?
Oh, well, yeah. So as a physician, health of the athlete is priority. I know sometimes we put under a lot of pressure because we're in the sports environment. But remember, an athlete who's in good health will perform well. And just as we deliver all our other health rules, anti-doping is one of them. So we should make sure that this is, we focus on this and we put in the necessary plans to ensure that that is well delivered. Have education as the start of this process, because compliance is really enforced by people being educated. And whenever we encounter anti-doping officials, it's really important for us to cooperate with them. And then as we pick very sensitive information about athlete health, we ensure that we keep it well and keep it safe. We probably disclose it only when necessary, and also just understand that we need to protect the athletes' rights. Just because we're doctors or medical professionals, we shouldn't abuse their rights. So yeah, that is my take-home message to the audience.
Thank you so much. Lots that we covered there. Really appreciate your time on this one, Carole. And I'm going to invite back Lucienne and Mark at this point as well. And while they just take a moment to get their cameras and mics back on, I did want to mention that we will be sending you the slides. There's some even more resources for you to take a look at when you do get the slides on email. We are also as well, colleagues of mine have teamed up with some students from the AISTS course. They are looking at perceptions on the impact of independence on the management of anti-doping activities. So if you could spare a few minutes of your time, we would love you to complete this survey. Thanks, Mark and Lucienne, as well, for switching your cameras back on. Mark, I saw that you were typing some answers into the Q&A as well. We're not going to have time to go through them all in this session, but maybe we could, take a couple of minutes each. Maybe Mark, rather than me sort of go through them one by one, is there anything there that you would like to highlight? And I will say that to those of you who have asked questions, the ones that have already come through by this point, if we don't answer live now, please do send us an email and we will be able to give you a written response. So first up, maybe Mark, just one minute from you.
Thanks, Mary. I've tried to answer a few questions that are in the chat there. Just very briefly, if an athlete is taking Tramadol, if they need it for during the competition, you must apply for a TUE for that. Because it's now prohibited in competition. There was a question from Gerald. Ashim, the team doctors for the Olympic Games are chosen by the National Olympic Committee. In terms of, there was a question there about the use of blood transfusions for car accidents. The health of the athlete must take absolute priority. You need to treat the athlete first, especially in emergency situations. You can always apply for a retroactive TUE afterwards. So these rules don't apply in those emergency situations. Apply for a retroactive TUE. That's very important. Most of the antihistamines are permitted in sport. Just be careful. Some of those do cause drowsiness and can impact on performance. Glucocorticoid nasal sprays are permitted. It's important to know at the normal manufacturer's license doses. That's an important message to get across to your athletes. That's some of the headlines. Thanks, Mary.
Thanks so much. And Lucienne, thank you as well. I hadn't realized you were also typing some answers as Carole and I were talking. So really appreciate that. Great that you managed to get through 15 of them, which is the majority of the questions. So that really leaves me the time to say thank you all so much to all three panelists for joining us. Really appreciate it. And I think you can see the comments that are coming through as well, that the audience all really benefited from each of your expertise there. So let me just wrap up the webinar. Thank you to our panelists. Thank you to the audience. If you do still have any questions, then please do drop us a line and we'd be very happy to get back to you as soon as we can. I'm going to leave our contact details. They're going to appear on the screen in just a moment. And as mentioned, if you don't have time to jot them down now, you will get the slides shortly after this webinar ends. Thank you all so much, and it's a good afternoon from me in Switzerland. Thank you.
Thank you.
Thank you.
Bye.